There's no question that glycemic control is important in preventing cardiovascular outcomes, but I would view it in a different way. I would sort of frame it out a different way. First of all, I don't look at treating one component of a complex disease. So cardiovascular disease is complex. There are many drivers that figure into the evolution, even the initiation, but the evolution of cardiovascular disease. No doubt diabetes is very important. Tobacco smoking is important. Cholesterol, a lot of the various modifiable risk factors are important. What hasn't served us well is to focus solely on one of those components and disregard not only the other components, but also some of the residual risk factors that we've learned are part of metabolic syndrome. Whether you believe metabolic syndrome is the right terminology or not, when you have a clustering of these risk factors, you increase your risk for cardiovascular disease. The cardiovascular outcome trials looking at the various SGLT2s and DPP4s and GLP1s have all insinuated that there are effects, there are pleiotropic effects beyond just glycemic control. Just like with statins, there are effects beyond just control or lowering of LDL. There are anti-inflammatory effects. So is the case with a lot of these diabetes medicines. In fact, one of the major emphasis in research now in these clinical trials is to see, are there class effects of benefit in risk mitigation for cardiovascular disease extending beyond glycemic control. So here's how I would do it. If a patient would come in to see me with type 2 diabetes with an A1C that's very high or even a little bit high, what I'm going to do is certainly draw attention to glycemic control, try to achieve my target for that A1C and a safe target. So it doesn't necessarily have to be 6.5 or 7. It may be just in the mid-7s if there's more risk associated with aggressive lowering, let's say in somebody who's elderly on a lot of other medications, or somebody who is on agents that increase the risk for hypoglycemia. But I'm going to also spend a lot of attention looking at the other component risk factors for cardiovascular disease, and I'm going to stress structured lifestyle. So even if you're committing to medicine, that doesn't obviate the need to press on with structured lifestyle change. We'll refer to a nutritionist, maybe go through healthy eating, go through proper physical activity, even some progressive resistance training, of which there are plenty of data using that in the elderly. Sleep hygiene, tobacco cessation, alcohol moderation, behavioral therapy. And as you're listening to this, you're saying, well, I don't really do this. And do we have an infrastructure that's capable of nurturing this kind of facility for endocrinologists to implement these types of lifestyle changes? The answer is no. We really need to, at a scale effect, change the way in which we view chronic disease in this country. We need to change policy. We need to change politics. It's a much larger picture, and that's why we need to get everybody on board, all of the healthcare professionals that are stakeholders in the epidemics of these chronic metabolic diseases.